its deceleration and coinciding with, yes. On repeat examination, cervix is 7 centimeter dilated, and there is, okay. These patients' fetal heart rate. This patient's fetal heart rate racing showing a normal baseline, moderate variability, and recurrent variable. Hello. Okay, recurrent variable deceleration caused by umbilical cord compression. Umbilical cord compression, which commonly occurs during contraction, impedes fetal placental blood flow. By occluding the umbilical cord blood vessel. Subsequent fetal hypoxemia and acidemia correlate with the ratio of umbilical cord compression to contraction. Intermittent umbilical cord compression, as evidenced by variable deceleration with less than 50% contraction, is typically well tolerated by the fetus. That is no hypoxemia and does not require intervention. In contrast, umbilical cord compression more than 50% contraction, as evidenced by recurrent variable deceleration, can result in lack of fetal placental blood flow and can cause hypoxemia and acidemia. First line treatment of recurrent variable deceleration is intrauterine resuscitation and maternal repositioning. Left lateral all force, which may reduce cord compression and improve fetal placental blood flow. If the variable deceleration do not improve, an amnioinfusion, installation of the saline into the uterine cavity can be administered artificially to create more amniotic fluid, which can reduce umbilical cord compression. Okay, for here, this is recurrent variable deceleration, not early deceleration, because I actually calculate wrong. Like, it is not from onset to nadir is less than 30 seconds, so it is early deceleration. So it is variable deceleration. From onset to nadir is less than 30 seconds. So variable deceleration has three causes: cord compression, oligohydramnios, and cord prolapse. So in here, cord compression can happen. So maternal repositioning to reduce the cord compression. If variable deceleration does not improve, then we can do amnioinfusion, like installation of the saline into the uterine cavity. Okay. Why we are not doing cesarean delivery? Because, yes, I want to read this option. Caesarean delivery is indicated in patients with absent variability and recurrent variable deceleration, like category 3 fetal heart rate tracing. This patient fetal heart rate tracing show moderate variability. Therefore, resuscitation should be attempted first. If the tracing were to become category 3, cesarean delivery would be indicated. Okay. Yes. And deceleration is the downward deflection of the this one, the slope. Yes. She has an uncomplicated term delivery. So it is very early. It it may be short pregnancy. There short pregnancy interval. There is a term called short pregnancy interval. It may cause prom premature rupture. As far I remember, less than 6 months. Normally 6 to 18. As far I remember. So if it is less than 6 months, less than 6 to 18 months from delivery to the next pregnancy, this is short pregnancy interval, and it can cause pre-prom. Is it like less than 6 to 18 months? The time range would be what? Like if it is before 18 months, then we will call it short pregnancy, or if it is less than only 6 months, or it is the whole time interval. Okay. The so like everyone should take a 2 hours break in one pregnancy, like as far this concern, like almost 2 hour or 2 years, sorry, 2 hour, not yes, yes, yes. So it is easier to remember, like take a break all at least 2 year from one pregnancy to another. Okay. Okay. Okay, it can cause the short pregnancy interval, can cause anemia, pre-prom, preterm delivery, and low birth weight. So pregnancy delivery and the postpartum period place increased physical and the metabolic demands on women in order to develop and provide nutrition for the fetus and the newborn. During pregnancy, maternal folate and iron are depleted for fetal development, and the resultant maternal anemia is exacerbated by normal blood loss during delivery, that is up to 10 to 20% of the blood volume. In the breastfeeding woman, continued nutritional demands from the newborn prevent repletion of the normal folate and iron store, resulting in prolonged anemia. Due to these increased demands, women with short pregnancy interval less than 6 to 18 months between delivery and the next pregnancy have increased risk of pregnancy complication, including low birth weight, preterm labor, pre-labor rupture of the membrane, possibly due to persistent genital tract inflammation. Therefore, appropriate pregnancy timing with interval contraception like progesterone containing intrauterine device is recommended for adequate maternal recovery and optimization for future pregnancies. Yes, a protracted labor course is more likely with advanced maternal age more than 35, fetal macrosomia, and increased inter-pregnancy interval more than inter-pregnancy interval more than 24 months. Risk is not increased by a short inter-pregnancy interval. She has chronic hypertension. Yes. Then we should not give one drug. Uh, Argometrin. Yes, maybe. Yes, you are on the right track. Like methyl argonovine. In our country, like argometrin actually used. Methyl argonovine, kind of same, uh, like same generic component, but in our country, argometrin. Argometrin causes continuous uterine contraction and thus it decreases bleeding. Okay, so postpartum uterine atony, uterine fatigue from prolonged or induced precip precipitous labor, intraamniotic infection, uterine overdistension, multiple gestation, macrosomia, polyhydramnios. So there may be retained placenta and grand multiple. 5 or more than 5 prior deliveries. Clinical feature: most common cause of post PPH, and enlarged soft bogey, poor contracted uterus. Intervention is bimanual uterine massage, contraction of bladder distension, high dose oxytocin, misoprostol, tranexamic acid, carboprost, methyl argonorvine, intrauterine balloon tamponade, possible surgical intervention if atony unresolved. This patient with profuse vaginal bleeding and a soft uterine fundus has uterine atony The most common cause of PPH, uterine atony, occurs because insufficient uterine contractility after delivery, resulting in continued bleeding from open placental blood vessel. Continued bleeding from open placental blood vessel. Risk factor include a grand multiparita, 5 or more than 5 deliveries, hypertensive disorder, and uterine overdistension like macrosomia. First line treatment for uterine atony. First line treatment for uterine atony is bimanual uterine massage and high dose oxytocin. Bimanual uterine massage and high dose oxytocin. If heavy vaginal bleeding persists, additional medication are administered based on patient specific contraindication. Tranexamic acid is an antifibrinolytic that prevents blood clot breakdown and significantly decreases blood loss if administered within 3 hours of delivery. If administered within 3 hours of delivery, therefore it is used for PPH of any etiology, uterine atony, retained placenta. Tranexamic acid has an absolute contraindication but is used with caution in patients with hypercoagulability, inherited thrombophilia due to potential increased risk of thromboembolism. Carbaprost tromethamine is a second-line uterotonic agent that stimulates contraindication to increase uterine tone and decrease bleeding. To increase uterine tone and decrease bleeding, it is a synthetic prostaglandin F2 alpha analog that can cause bronchospasm and therefore it is not contraindicated in patients with asthma. It is contraindicated. Okay, carboprost is contraindicated in patient with asthma, and methyl argonorvin is another second line uterotonic agent that stimulate contraction. It is a potent vasoconstrictor and therefore contraindicated in patients with hypertensive disorder. These patients with chronic hypertension due to risk of stroke. Do you want me to read the other option? Okay. In asthma, hypertension, yes. There is no contraindication in misoprostol. Misoprostol. Like option C. Uh, okay, no contraindication. Misoprostol is used for induction of labor or a second line uterotonic to treat the uterine atony. Okay, misoprostol also can be used, though it is second line. There are typically no contraindication to the use of either oxytocin or misoprostol in patients with PPH. Okay, okay, got it. Uh, look at this point. A placenta covering the internal cervical os. When placenta covers, yes, in the second trimester we do routine ultrasound to look for any, like, is there any placenta previa or is there something, because sometimes what happens, if somebody has placenta previa, it may uh, the as it just covering the internal os, the covering may subside, and the no, 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 you are on the right track. She has no bleeding, they haven't talked about any sort of bleeding, so why we should care? Okay, okay. Placenta previa, prior cesarean delivery, and multiple gestation, painless vaginal bleeding at more than 20 weeks of gestation, transabdominal followed by transvaginal sonography, no intercourse, no digital cervical examination, and inpatient admission for bleeding episodes. So, placenta previa is diagnosed during routine prenatal is diagnosed during routine prenatal ultrasound, 18 to 20 weeks of gestation, with placental issue covering the cervix. Most patients are asymptomatic but have significant risk of severe painless antepartum hemorrhage due to partial placental detachment with cervical manipulation or dilation. The majority 90% of the cases the majority 90% the majority of cases resolve spontaneously due to lower uterine segment lengthening and placental growth towards the fundus, and therefore initial management is with routine obstetric care, pelvic rest, and abstinence from intercourse due to placental cervical con- contact due to potential cervical contact and recommended, and clinicians should refrain from digital cervical examination. Repeat ultrasound is performed in the third trimester at more than 28 weeks of gestation, and patients with placenta previa resolution can continue routine care without pelvic rest restriction. Asymptomatic patients with no vaginal bleeding with persistent previa should undergo cesarean delivery at 36 to 37 weeks of gestation. 36 to 37 weeks. Yes, CNE. Progesterone supplementation may reduce the risk of preterm birth in patients with prior preterm birth by intramuscular hydroxyprogesterone or those with incidental short cervix with vaginal progesterone. These patients prior pregnancy were delivered at term and her cervical length is normal more than 2.5 centimeters. Yes. It is not laceration, coagulopathy, or retained placenta. It is like giving excessive traction may rupture or uterine inversion. Maybe uterine atony can cause PPH. It is postpartum hemorrhage, isn't it? So, number one cause of postpartum hemorrhage is atony. Uterine inversion, uh, it can occur due to excessive traction, but okay, okay. First, look at the uterine inversion. Okay, I was confused. Uterine inversion, like uterus is coming due to excessive traction. So uterine inversion can occur due to excessive traction on the umbilical cord with an adherent placenta, causing the uterine fundus to invert and prolapse. Although it can cause PPH, patients typically have severe abdominal pain and smooth mass protruding from the cervix or vagina, and no palpable uterine fundus. Okay, this patient with heavy bleeding and blood clot in the lower uterine segment has uterine atony. The most common cause of PPH within 24 hours delivery. Uterine atony occurs due to insufficient uterine contraction. Sufficient, sorry. Uterine atony occurs due to insufficient uterine contractility, resulting in the ability of the uterus to clamp down the bleeding placental bed vessels. Risk factors include uterine overdistension, often associated with fetal macrosomia, weight more than 4 kg, uterine fatigue, and prolonged induction of the labor and operative vaginal delivery, forceps assisted, all of which are present in this patient. Normally, during the immediate postpartum period, contraction increase uterine tone, causing firm uterine fundus to be palpable at or below the umbilicus. In patient, in contrast, patients with uterine atony have a soft, boggy, enlarged uterus with the fundus palpable above the umbilicus. Because of decreased uterine tone, some patients may not have an immediate PPH, such as this patient whose bleeding was identified 60 minutes after delivery. Because blood supply can gradually accumulate in the lower uterine segment, the least contractile portion of the uterus. Okay, next. Okay, you want me to read the retained placenta option? Okay, next. BP is slightly low. Oh, first, we give oxytocin, isn't it? Okay, okay, I am looking for this management actually. Yes, okay. So, management of PPH, postpartum hemorrhage, soft, boggy, soft boggy uterus. Step 1 is uterine massage and high dose oxytocin. Uterine massage and high dose oxytocin. In step 2, tranexamic acid. And in step 3, second line. In step 3, second line uterotonic. Methyl argonovin contraindicated if there is hypertension. Carbaprost contraindicated in asthma, and misoprostol can be given. So oxytocin, okay, uterine massage, oxytocin, tranexamic acid, then the second line, then intrauterine balloon tamponade, and finally laparotomy. Estimated blood loss more than 1000 ml or bleeding with hypovolemia. Okay. So postpartum hemorrhage is defined as estimated blood loss more than 1000 ml or bleeding with signs or symptoms of hypovolemia. The management of the PPH due to uterine atony occurs in a stepwise approach. Initial management includes the placement of two large bore IV lines for volume resuscitation, bimanual uterine massage, and bladder catheterization are performed to improve uterine tone. High-dose oxytocin, the first-line uterotonic agent, is administered if uterine atony persists. The best next step in management is tranexamic acid, antifibrinolytic agent that prevents the breakdown of blood clots to achieve hemostasis. It reduces maternal mortality from hemorrhage. Patients with continued bleeding are administered second-line uterotonic medication including carbapost, tromethamine, methylargonorvin, and misoprostol. Carbapost, tromethamine is contraindicated in asthma due to risk of bronchospasm. Methylargonorvin is contraindicated in patients with hypertension due to increased risk of stroke. If PPH does not resolve with medical therapy, if PPH does not resolve with medical therapy, if PPH does not resolve with medical therapy, an intrauterine balloon tamponade can be used to compress the placental bed blood vessel for hemostasis. Finally, patients with PPH refractory to medical and minimally invasive technique require either uterine atony embolization or surgical management with laparotomy and possible hysterectomy. Okay. Okay, can you give me a break of 5 minutes? I'm feeling very drowsy. Okay. Is high alkalosis. low. Respiratory alkalosis. Mm. But has not required antihypertensive. But there is, I as respiratory alkalosis. Maybe it is a physiological problem. May not be.
Yeah, it is.
Yesterday I got plenty of wrong due to overconfidence. Okay, so this patient lab results include a high pH and a low PCO2, high pH and low PCO2, and low serum bicarbonate. Finding consistent with primary respiratory alkalosis with renal compensation, chronic hyperventilation. Chronic hyperventilation is a normal physiologic change in the pregnancy triggered by elevated progesterone which accumulates respiratory drive to meet the metabolic demand and create the sensation of dyspnea. Hyperventilation of the pregnancy mostly involves increased tidal volume with a minimal increase in respiratory rate, the expanding although the expanding uterus causes upward displacement of the resting position of the diaphragm, and diaphragmatic excursion is impaired, allowing for the increase in tidal volume. Hormone induced laxity of the intercostal muscle also enlarges the thoracic cavity, further contributing to the increase of tidal volume. In addition to decreased PaCO2, hyperventilation leads to increased PaO2. Pregnant patient with isolated mild or moderate dyspnea. Pregnant patient with mild to moderate dyspnea therefore provided reassurance without further diagnostic testing. Oh, okay. However, in the presence of findings suggestive of cardiopulmonary disease, further evaluation should be performed. Further evaluation should be performed. Echocardiography is initiated for evaluation of the peripartum cardiomyopathy, which manifests during the last month of the pregnancy or within 5 months of post-delivery. This patient is too early in the pregnancy. Signs of decompensated heart failure, lung crackles are expected. This patient's systolic murmur is likely a flow murmur due to physiologic expansion of the blood volume, and her ankle edema is explained by uterine compression of the inferior vena cava. Okay. Yes. Is it abruptio? Is it preterm labor? For preterm pre-labor rupture of the membrane, we need nitrogen test to be positive, isn't it? So it is incomplete abortion. It is cervical insufficiency. Okay, I don't know the answer actually. Cervical insufficiency, mm, collagen defect, uterine abnormality, and cervical collagen defect, uterine abnormality, and cervical conization, obstetric injury. Clinical feature two or more than two painless second trimester loses and painless cervical dilatation. Management is circulation placement. This patient has cervical insufficiency. This patient has cervical insufficiency, a structural weakness of the cervix causing spontaneous painless cervical dilatation, and potential second trimester pregnancy loss. Risk factor include collagen abnormalities, Ehlers-Danlos syndrome, uterine abnormalities, septate or bicornuate uterus, prior obstetric trauma, and cervical conization. So what does she has? What's her risk factor? Um, Patients, sorry, I, I haven't found anything to match with. Okay, just cervical dilatation. Think about cervical insufficiency. Okay, okay. Patients with cervical insufficiency, even those presenting with advanced cervical dilatation, typically have only mild symptoms such as increased vaginal discharge due to loss of the mucus plug, light vaginal bleeding due to cervical stretching, and pelvic pressure due to fetal parts distending the upper vagina. Fetal part distending the upper vagina. Patients with can be diagnosed on examination, which reveals visible cervical dilatation and no uterine contraction. These patients are typically managed with rescue circlage, in which suture is placed to reinforce and add tensile strength to the cervix to prevent further dilatation. However, in patients who have bulging or prolapsing amniotic membrane, a rescue circlage is not typically recommended due to high risk membrane rupture, complication, intraamniotic infection, cervical trauma, and likely imminent delivery. Okay, if you want, okay, I'm reading. Choice A. No, if you need any option, then I can read. If you don't, then we can continue. Okay. Abruptio placentae may cause bloody vaginal discharge, but it typically presents with painful. So abruptio placenta comes with painful contraction and uterine tenderness, which are not seen in this patient. An incomplete abortion which can present with cervical dilatation and fetal parts of the and fetal parts at the cervical os. However, it is defined as pregnancy loss at less than 20 weeks of gestation, whereas this patient is at 21 weeks. In addition, it is typically painful due to uterine cramping. In further pregnancy management of the patients with prior spontaneous abortion is typically expected. In contrast, those who meet the criteria for cervical insufficiency may benefit from a prophylactic circulation. Okay, option D, in contrast to the patient's painless presentation, patients with preterm labor typically have regular painful uterine contraction leading to cervical dilatation. Okay. Okay. I don't know. One, one. She has problem. What was her problem? Just increasing nausea and the frontal headache. Is it the signs of the eclampsia? There is ketone present. Why ketone? Oh, blood. Okay, glucose is negative urine drug. CT scan of the head show bilateral frontal edema. Okay, it's not tryptin abortive therapy. It's not. Yes, Maxulf for it. It may be eclampsia. Okay, this is the sign of BP may not be that high, but the other signs like deep tendon reflex, headache, these are the signs of the eclampsia. Yes. Okay, eclampsia, preeclampsia with new onset seizure, hypertension, typically severe, systolic blood pressure more than 160 and diastolic more than 110. Systolic more than 160, diastolic more than 110. Seizure typically tonic-clonic with post-ictal phase, severe headache, visual disturbance, scotoma, hyperreflexia, proteinuria. Diagnosis mainly clinical bilateral frontal edema on CT scan of the head. On CT scan of the head, magnesium sulfate infusion, antihypertensive agent for severe hypertension and delivery. This patient was found unconscious and gradually become more responsive. This patient was found unconscious and gradually become more responsive, suggestive of post-ictal state. She also has a headache and hypertension defined in pregnancy of systolic blood pressure more than 140 and diastolic more than 90 millimeter of mercury with severe hypertension defined as systolic blood pressure more than 160 or diastolic more than 110, consistent with preeclampsia with severe feature. Preeclampsia accompanied by new-onset seizure is diagnostic of the eclamptic seizure. Patients with preeclampsia are at risk of developing generalized tonic-clonic seizure eclampsia due to generalized tonic-clonic seizure eclampsia due to preeclampsia induced cerebrovascular dysfunction, vasospasm with subsequent brain edema. Although eclampsia typically presents with seizure activity, many patients are found in the post-ictal state uh, because eclamptic seizure are usually brief, less than 1 minute. As in this patient, the postictal confusion and unresponsiveness typically resolve in 10 to 20 minutes, but a patients with but patient can continue to have signs of preeclampsia with severe feature such as severe headache, nausea, vomiting, hyperreflection, elevated creatinine. Eclampsia is a clinical diagnosis. However, CT scan of the head is performed in patients with atypical or prolonged symptoms and usually reveals bilateral frontal or occipital lobe edema as seen in this patient. Because eclamptic seizures can cause brain injury and increase risk for stroke. Eclampsia requires emergency treatment with Maxalf infusion to prevent the seizure recurrence. Fetal delivery is required for definitive. Okay, CT venography for CVST which may present with severe headache and seizure. However, CVT, cerebral venous thrombosis, typically causes papilloedema and focal neurological defects which are not present in here. Okay. I don't know. I don't know why this. Hello. Okay. According to this graph, like from 4 hour to 8 hour, there is only 1 centimeter dilatation. If there is a multi-gravita, So I think that more than 2 or 3 centimeter dilatation should be needed uh, for per hour or for next 4 hours. So it is not, dilatation is of cervix is not adequate. So why is the problem? It's not maternal but is it CPD, cephalopelvic dysfunction? What is the problem? Not contraction strength, or or it is given or it is due to anesthesia. The It is due to cephalopelvic dysfunction, isn't it? It is protracted active phase of labor. That means it is not moving adequately. The head is not moving down adequately. Okay. Okay. The first stage of labor. The first stage of labor from start on the first age of labor from start of the contraction to 10 centimeter dilatation. 10 centimeter cervical dilatation includes a latent and an active phase. The active phase is 6 to 10 centimeter and latent phase is 0 to 6 centimeter. The active phase of labor 6 to 10 centimeter of cervical dilatation has been expected. Predictable rate of cervical dilatation is 1 or more than 1 centimeter every 2 hours. This patient reached active phase 6 centimeter dilatation when she received her epidural 2 hours after the admission. She then progressed appropriately from 6 to 7 centimeter of the cervical dilatation over the next 2 hours. Cervical dilatation 1 centimeter per 2 hour. 6 to 7. Okay. After giving anesthesia. Okay. However, her cervix only 1 centimeter between hours 4 to 8, less than 1 centimeter every 2 hours, consistent with active phase protraction. Protraction is commonly caused by cephalopelvic protraction is commonly caused by cephalopelvic disproportion in which the fetal head is too large to fit through the maternal pelvis. Cephalopelvic disproportion is more common in late term pregnancy, 41 or more than 41 weeks of gestation, or in weeks of fetal anomaly or malposition occiput posterior. Additional risk factors include maternal obesity, excessive weight gain, nulliparity, advanced maternal age, and inadequate contraction. Inadequate contraction. Okay. Yes. Hypocontractile uterine cavity. Hypocontractile uterine cavity inadequate contraction can lead to labor protraction. However, these patients' contractions are adequate 200 more than 200 Montevideo unit as measured by intrauterine pressure catheter increasing their strength above 200 Montevideo unit would not change the labor curve. Option C, fetal gestational age more than 41 weeks of gestation, late term pregnancy can be a risk factor for protracted or arrested labor due to larger fetal size. This patient is at 39 weeks of gestation. Option D, nulliparous patient primary cavity experience slower first or second stage of labor, compared with the paras patient multigravitas. This patient has 4 prior to term vaginal deliveries, which would predict an accelerated non-protracted labor. And option E, neuroaxial anesthesia. Epidural can lengthen the second stage of labor, 10 centimeter dilatation until fetal delivery, but not the first stage. This patient is in the first stage of labor, although her labor becomes protracted less than 1 centimeter per 2 hour. starting an hour 4 independent of her epidural placement at hour 2. If you understand the curve, then it is easy. Like look, from 6 to 7 centimeter, like from 2 hour to 4 hour. In this 2 hour, there is 1 centimeter dilatation. Cervix is dilated in 1 centimeter. In this 2 hour, she has got the anesthesia. So it is normal. So anesthesia is not causing the, not halting the dilatation. Then from 4 to 8 hours, there is less than 1 centimeter dilatation. In these 4 hours, minimum 2 centimeter dilatation should be needed. So there is a less than 1 centimeter dilatation. That means it is not passing through the canal. So that's why it is the head is halting due to cephalopelvic disproportion. Maybe. Okay, look at the picture first. Yes. So fetal bradycardia. What are the causes of fetal bradycardia? So we need to remember that first. Okay. Mm, yes. Okay, what's your diagnosis according to the picture? Lupus. Okay. And lupus causes fetal heart block, and we diagnose it by anti-Ro antibody. Rola. Okay. This patient with fatigue joint pain, and malar facial rash. Fatigue joint pain, malar facial rash most likely has SLE. SLE, like other autoimmune disease, may improve, worsen, or initially present during delivery. Patients with SLE have increased risk of obstetric complication, which can be normal, which can which can be maternal preeclampsia or fetal neonatal lupus or intrauterine fetal demise. Neonatal lupus occurs due to passive placental transfer of the maternal anti-Ro, maternal anti-SSA, and anti-SSB La antibodies, which commonly occurs in Sjogren's syndrome, but are also seen in 30% patients of the SLA. Fetal findings are primarily cardiac and cutaneous scalp or periorbital rash. The most serious complication is fetal AV block, which develops at 18 to 24 hours of gestation. The most likely These likely occurs due to maternal autoantibodies binding to fetal cardiac cell, causing irreversible injury to the AV node. Without a normal AV conduction, the ventricular heart rate 50 to 80 per minute determines the baseline fetal heart rate. However, fetal heart rate tracing these appears as persistent fetal bradycardia less than 110 per minute. With prolonged complete heart block, cardiomyopathy and hydrocephalus may develop. Therefore, patients with decreased fetal movement requires additional testing and biophysical profile, fetal heart growth, ultrasound, and possible delivery. Okay. Okay. Absolute contraindication to pregnancy. Absolute contraindication to pregnancy. Pulmonary arterial hypertension, peripartum cardiomyopathy with residual left ventricular dysfunction, heart failure with left ventricular ejection fraction less than 30%, severe coarctation, severe MS, severe symptomatic aortic stenosis, and severe aortic dilatation. That is Marfan syndrome. Management is against recommend against pregnancy at preconception counseling visit. If patient discuss abortion, if abortion declined, regular cardiology follow. The preconception visit allows this patient with a variety of the medical condition to discuss the risk and the benefit of pregnancy while formulating plans to optimize their medical comorbidities to reduce maternal fetal morbidity and mortality. In some cases, such as this patient a peripartum cardiomyopathy and a persistently reduced ejection fraction less than 30%, the risk of maternal mortality during pregnancy is so high that not the pregnancy is not recommended. This is because peripartum cardiomyopathy causes left ventricular dilatation and subsequent systolic dysfunction in patient with partial recovery of the ejection fraction normal more than 50%. The hemodynamic stress of the pregnancy is associated with high maternal mortality due to left ventricular arrhythmia and thromboembolic events, worsening ventricular function, and even sudden sudden death. The risk of death is substantial with reduced ejection fraction as seen in this patient and despite symptom improvement. Okay, next. Oh, okay, there is something. Okay, okay. Although reproductive Although reproductive decisions are personal choices, of pregnancy, the potential complications of the pregnancy must be addressed to prevent harm. However, when pregnancy poses a substantial risk of life, of the mother. Direct counseling, a type of uh, sorry. However, when pregnancy poses a substantial risk of life of mother, directive counseling, a type of counseling employed when there is only one safe, reasonable, and clearly superior clearly superior evidence based option should be performed. In this case, the primary duty of the physician is to act the in the best interest of the patient beneficiaries and avoid potentially harmful adverse effects or non-maleficence, even if it conflicts with the patient's autonomy. Therefore, the most appropriate course is not recommend pregnancy in this patient, even if the patient understands the risk even if the patient understands the risk and still desires pregnancy. If the patient becomes pregnant and declines abortion, regular cardiology follow-up is indicated. Other contraindications to pregnancy include pulmonary arterial hypertension and heart failure with left ventricular ejection fraction less than 30%, severe aortic dilatation, and severe MS or AS. Okay, next. Abruption placenta can cause something. You're right, abruption placenta. Yes. Okay, this patient with severe abdominal pain. So this patient with severe abdominal pain and vaginal bleeding likely has abruption placenta. Placental abruption is retroplacental bleeding that occurs when the placenta and the uterine decidua can cause the placental detachment and the vaginal bleeding. The accumulation of blood in the space cause increase intrauterine pressure, lower abdominal or back pain, a firm tender uterus, and a high frequency contraction. Preeclampsia, hypertension, proteinuria, and tobacco use are risk factors. Some cases of abruption placenta are self-limited and clinically insignificant. However, as more of the placenta detaches, there is greater risk for maternal and fetal complication. Maternal complication include hemorrhage, hypovolemic shock, DIC, due to tissue factor related in response to decidual bleeding. Potential fetal complication include impaired perfusion, abnormalities of the heart rate, tracing if hypoperfusion persists and hypoxia develops, and fetal demise. Okay. Large palpable mass. Large palpable mass. Um, is it in between the D and F? Or but her BP is low, 90/50. Uh, it is vaginal. Okay. So this patient hypovolemic shock. This patient hypovolemic shock and protruding vaginal mass is likely due to vaginal hematoma, a potentially life-threatening postpartum complication during the delivery. During delivery, stretching of the vaginal canal. During delivery, stretching of the vaginal. Hello. Okay. During delivery, stretching of the vaginal canal can injure the uterine artery, particularly the nulliparous patient undergoing operative vaginal delivery, forceps assisted, or delivering an infant more than 4 grams. The resultant injury can cause massive postpartum bleeding as the uterine artery during pregnancy enlarges and supplies the uterus up to 30% of the total cardiac output. Because the blood collects the paravaginal space, patients often have massive occult bleeding evidenced by hypovolemic shock, hypotension, tachycardia, and diaphoresis initially. However, as blood continues to collect within the paravaginal tissue, patient can develop a protruding vaginal mass, often associated with rectal or vaginal pressure and minimal vaginal bleeding. How hematoma are managed based on hemodynamic stability, whether they continue to expand. Non-expanding vaginal hematoma are observed, whereas expanding hematoma require treatment and arterial embolization surgery. Okay. Okay. Proper breastfeeding technique. Proper breastfeeding technique promotes maternal comfort and ensures adequate infant's nutritional intake and facilitates long-term breastfeeding. Most breastfeeding patients experience nipple pain in the immediate postpartum period as they become accustomed to nursing 8 to 12 times per day or more, but this typically resolves after a week's nipple pain that worsens and persists between feedings is commonly due to nipple injury caused by poor infant positioning and improper latch-on technique. On examination, patients can have open linear abrasion that can cause bloody appearing nipple discharge. Bruising, cracking, and blistering may also present. Breast engorgement may, as seen in this patient with bilateral diffusely and tender and engorged breast, can also develop because nipple pain limits breastfeeding. In management with observation of breastfeeding and patient education, nipple injury is a significant risk factor for multiple adverse outcome: plucked milk duct, mastitis, breast abscess, which often lead to premature cessation of breastfeeding. Okay. Is it oligohydramnios? And in oligohydramnios, the problem is in the kidney, because what amniotic fluid is made by the kidney, it is engulfed by the baby. So low structure membrane, normal there. Okay. This patient has oligohydramnios and amniotic fluid less than 5 centimeter. The etiology of the oligohydramnios can vary with gestational age. Early gestation oligohydramnios is concerning for fetal etiology, aneuploidy, aneuploidy, renal agenesis, posterior urethral valve, because amniotic fluid volume is dependent. Amniotic fluid volume is dependent on normal fetal urine production. Amniotic fluid volume is dependent on normal fetal urine production. Second and third trimester causes oligohydramnios are typically due to uteroplacental insufficiency with concomitant fetal growth restriction, or maternal causes such as dehydration or rupture of the membrane with normal fetal growth. At term gestation, the most likely cause of new onset oligohydramnios is spontaneous rupture. At term, it is spontaneous rupture of the membrane, although membrane rupture typically presents with sudden gush of fluid. Patients can have subclinical presentation with slow leakage occurring over days, such as this patient, with an increase with increased clear vaginal discharge. Patient Because rupture of the membrane is common in oligohydramnios, and even asymptomatic patient with oligohydramnios require examination to evaluate for membrane rupture. Okay. Okay, this patient's pruritus is most severe in the palms and is associated with rash and is consistent with intrahepatic cholestasis of the pregnancy, which typically occurs during the third trimester. Intrahepatic cholestasis of the pregnancy (ICP) is likely due to increased estrogen and progesterone that cause hepatobiliary tract stasis and decreased bile excretion. These result in elevated total bile acid. Bile acid more than 10 micromole per liter, diagnostic of ICP, and can cause a generalized intractable pruritus that is worse on the palms and the soles. Some patients have right upper quadrant pain and elevated aminotransferase. ALP is often elevated but is not specific for ICP because it is produced by placenta. ICP, intrahepatic cholestasis of the pregnancy, does not increase the risk of maternal complication. However, due to transplacental passage of bile acid, it does not increase the risk of fetal complication, intrauterine fetal demise, meconium, stain, amniotic fluid. For these reason, management include of both treatment of the maternal for treatment of maternal pruritus and prevention of fetal complications. First line treatment with ursodeoxycholic acid, which relieve pruritus and may decrease obstetric complication. In addition, patients require regular fetal assessment, non-stress test, and delivery at 37 weeks of gestation. Yes. Emergency delivery and max emergency delivery and max may be indicated in patients who have chronic hypertension with superimposed preeclampsia or acute fatty liver of the pregnancy. Superimposed preeclampsia presents with hypertension, systolic 140 millimeter mercury and diastolic more than 90 millimeter mercury, and may cause elevated aminotransferase 2 or more than 2 upper limit of the normal. Uh, in contrast, acute fatty liver of the pregnancy may present with hypertension but always causes elevated aminotransferase, usually 5 to 10 times of the normal range. These diagnoses are likely because neither condition can elevate total bile acid, and it is normotensive. Okay. Yes. And then 34 to 37 APT, antenatal AP, antenatal corticosteroid and penicillin. Is it, am I right? Her group B streptococcus is positive. We should give penicillin because already after 32 weeks corticosteroid is uh, like corticosteroid start producing, like steroid start producing it, so it is not given. Okay, look at the option A. Betamethasone is administered to patients with at risk of preterm delivery less than 37 weeks of gestation to promote lung maturity and decrease the risk of neonatal respiratory distress syndrome. No, it's not because 37, as she has positive group B streptococcus, like group B asymptomatic. This is more important than giving steroid because as far I know, corticosteroids is given in early because the lung is not mature enough, but after 32 the lung is mature enough and it can produce its corticosteroid, so we do not need, but can be given. Okay, if group B streptococcus is negative, then we can give. Okay, group B streptococcus is a common colonizer Uh, Group B Streptococcus is a common colonizer. Mm, Group B Streptococcus is a common colonizer of the gastrointestinal and genital tract. Group B Streptococcus is typically asymptomatic in pregnant patients, but it can be vertically transmitted to the neonate during vaginal delivery or with rupture of the membrane, resulting in early onset neonatal infection, sepsis, pneumonia. To decrease the risk of vertical transmission, most women are screened at 36 to 38 weeks of gestation by rectovaginal culture and administered intrapartum antibiotic prophylaxis if they are GBS positive. However, some women do not undergo GBS screening and they are considered to have persistent heavy GBS colonization, high bacterial load, and therefore increased risk for vertical transmission. Markers of heavy maternal colonization includes group B asymptomatic bacteriuria as in this patient, and group B urinary tract infection, group B streptococcus urinary tract infection during the current pregnancy regardless of the symptoms. Another marker of heavy group B streptococcus colonization is a prior delivery of an infant with early onset neonatal sepsis infection, which is typically due to GBS. These women with a heavy colonization require intrapartum antibiotic prophylaxis penicillin regardless of screening status of rectovaginal culture. Okay. Is it ectopic? Beta ECG more, more than 3,500. If there is chorionic villi, then it would be the GTT, like gestational tropoplastic disease, like hydatidform or choriocarcinoma. And in here, beta ECG would be very high. Okay, okay. Okay, management of suspected ectopic pregnancy. Management of suspected ectopic pregnancy, positive urine HCG, lower abdominal pain, and or vaginal bleeding, hemodynamically unstable, immediate surgical consultation. If no, hemodynamically stable, then transvaginal ultrasound. Adnexal mass treat for ectopic pregnancy. If transvaginal ultrasound show intrauterine pregnancy or non-diagnostic. Then we do serum beta ECG level. If serum beta ECG level is more than 350/100, repeat beta ECG level plus transvaginal ultrasound in 2 days. If it is less than 3500, repeat beta ECG level in 2 days. No need to do transvaginal ultrasound. The most common reason for early pregnancy monitoring is first trimester bleeding, as in this patient, first trimester bleeding, as in this patient with vaginal spotting. Initial evaluation is with transvaginal ultrasonography and serum beta ECG measurement. This patient had an initial beta ECG less than 3500, which is below the discriminatory zone or the threshold at which gestational sac should be visible on ultrasound in the pregnancy is intrauterine. Patient with pregnancy below the discriminatory zone often have non-diagnostic ultrasound finding, small pseudosac, centrally located fluid collection, and non-adnexal mass, and therefore are diagnosed with a pregnancy of unknown location. The pregnancy could be intrauterine viable or non-viable or extrauterine ectopic. Because of 90% of the viable pregnancy, including early pregnancy below the discriminatory zone, have 35% rise in the beta ECG, 35% rise in the beta ECG in 24 hours. A repeat beta ECG level can help to diagnose an abnormal rise in the beta ECG. Less than 35% increase in 24 hours in this patient indicate a non-viable pregnancy, or ectopic pregnancy. Because a viable pregnancy is unlikely, patients with abnormal rise in the beta ECG can undergo DNC, dilatation and the curettage, which determines pregnancy location of an intrauterine content. An abnormal intrauterine pregnancy, including a recent complete spontaneous abortion, will have chorionic villi, a finding consistent with intrauterine placental development, and in contrast, the intrauterine content associated with ectopic pregnancy will have ectopic pregnancy no chorionic villi due to their extrauterine pregnancy implantation. Therefore, this patient has no chorionic villi on dilatation and the curettage as an ectopic pregnancy. An ectopic pregnancy. Okay. If there is chorionic villi, it may be complete abortion. What? Uh, Option A, complete spontaneous abortion. So, an abnormal intrauterine pregnancy, including a recent complete spontaneous abortion, will have chorionic villi, a finding consistent with intrauterine placental development. So, if we find chorionic villi, then it would be abortion. Okay. Yes. Yes. Okay, even if it is transverse lie, so baby will likely return to its correct position of its own. Okay, this fetus has a transverse lie. A fetal spine is perpendicular to the long axis of the fetus and shoulder presentation. Shoulder is the fetal body part closest to the cervix. At an earlier gestational age, the fetus is mobile and is due to small size when compared with the amniotic fluid volume and intrauterine cavity size. These abnormal fetal lie and malpresentation are common and frequently change. With the increasing gestational age, increasing fetal growth, and relative decrease amniotic fluid volume, decrease to fetal mobility. By term more than 37 weeks of gestation, the majority of the fetus will have spontaneously rotated into a longitudinal lie. Fetal spine is parallel to the long axis of the uterus and cephalic presentation as this prepares to the fetus for delivery and is the most effective way to occupy the intrauterine cavity. Therefore, patients with transverse lie and malpresentation at preterm gestation manage expectantly mm, with an ultrasound term to evaluate for presentation. Okay, yes. External cephalic version ECV, a procedure in which fetus is manually rotated to cephalic presentation, can be performed in patients with malpresentation more than 37 weeks of gestation, but not in preterm patient. Most fetus will spontaneously rotate. In addition, ECV has a risk of pre-labor rupture of the membrane and abruptio placentae, which will which require delivery. ECV is not recommended during active labor due to its low success rate at the time. Okay, okay, let's take a break. Yes.